Well, hello. This is Professor White, and welcome to this lecture on antihistamines, decongestants, antitussives, and expectorants. So basically medications that are used to treat some of the most common complaints that our patients will have. I don't think that there's any one of us that hasn't already caught a common cold, and the same is true of our patients. This is something that is very common. There are a ton of different viruses out there that can cause sort of these upper respiratory infection signs and symptoms. The most common among them are actually going to be the rhinovirus and the influenza virus. So what happens with the pathophysiology with a common cold is that basically a virus invades the mucosa of the upper respiratory tract, so those tissues, that's mucosa, and this causes the upper respiratory infection. And as a result, there's an inflammatory process which causes an increase in mucus production. And too much mucus production starts to give us some of those signs and symptoms that we will see in the patients, which is coughing, sore throat, upset stomach. And this is from, usually the upset stomach's caused from some of the dripping and swallowing of secretions, sneezing, and of course nasal congestion. When the nasal mucosa gets irritated, that's what often triggers the sneeze reflex, and then the nasal congestion is caused by mucosal irritation that releases some of these vasoactive substances, which causes dilation of the small vessels in the nasal sinuses. So that's just a little bit of information about why the signs and symptoms occur. So the treatment of the common cold usually centers around supportive care. All right, so this is very symptomatic care. It doesn't cure it. The body will naturally clear the virus. So the common symptomatic treatments would include things that I have listed here: your antihistamines, nasal decongestants, antitussives, the expectorants. Now, antivirals may possibly be used, but in the case of antivirals, there are limitations to those, and also antibiotics are not used for viral infections. However, some patients develop secondary bacterial infections, and at which point that would be an appropriate treatment. Another thing to note is that a lot of times when we really just can't identify exactly what the causative agent is, that might be a reason that instead we might use empiric therapy. So empiric means treating the most likely cause. All right, so let's take a look at the kiddos here real quick. So back in 2008, the US FDA, so that's the Food and Drug Administration, had actually issued recommendations on the over-the-counter products for cough and cold that they should not be used on kids under than 2 years of age. There were a lot of problems with giving these medications to the babies and the young children, and that included the oversedation, seizures, and even death. And really, they just don't work for our youngest of the youngest. So the recommendation is that anybody who has a child that is younger than 2 years of age needs to speak with their pediatrician regarding what the appropriate treatment for their cough, cold, upper respiratory symptoms may be. And the good thing is that a 2010 study did show a dramatic decrease in young children's ER visits since that recommendation. So this is stuff that's working. So histamines are chemicals that the immune system releases. It's mainly known for its role in causing allergy symptoms, but it has other important functions like regulating the sleep-wake cycle, cognitive function, and antihistamines are common medications that help manage histamine levels. So there are two specific histamine receptors that we'll talk about in our course. Now, there's actually more than that, but for what we need to know about, it's really the two of them, which we'll talk about on the next slide. but some of the things for histamine release, so bear with me for just a moment. So as I was saying, histamine is an inflammatory mediator in many allergic disorders, and these would include things like allergic rhinitis, like hay fever, mold, dust allergies, anaphylaxis, of course, which is a huge histamine mediated reaction, angioedema, drug fevers, insect bite reactions, and urticaria, which is itching. So let's take a look at here. So remember, anaphylaxis is an excessive amount of histamine. So the antihistamines, the drugs that we're going to be concerned with, basically compete with histamine for receptor sites. So we have the histamine receptors are H1 and H2 that we need to be concerned about. So those are the two main types of histamine receptors that are targeted by the different antihistamine drugs to treat a variety of conditions. Now, H1 receptors are found in many body tissues, and these would include things like the immune cells, endothelium, and smooth muscle. They play a really key role in regulating bronchoconstriction, atrial muscle contractibility, and vasodilation. So antihistamines that bind to H1 receptors are used to treat allergic conditions like hives, itchy skin, runny nose, so on and so forth. Now, H2 receptors are mainly found in the parietal cells of the stomach, which produces gastric acid. So antihistamines that bind to the H2 receptors are used to treat upper GI conditions caused by excessive stomach acid, such as peptic ulcers, GERD, Zollinger-Ellison syndrome. And you will see them also used as adjuncts because of the antihistamine action for sometimes anaphylaxis. So our antihistamines, they block the action of histamine at the receptor sites. Remember, they compete with histamine for the binding of unoccupied receptors, but the trick is they can't really push histamine off a receptor if it's already bound. So these medications are better used to prevent histamine reactions rather than treating them. So H1 antagonists, those H1 blockers, the examples are here for you. So Benadryl, so diphenhydramine, chlorpheniramine, fexofenadine, loratadine, cetirizine. So those are all H1 antagonists. And then our H2 blockers or H2 antagonists, you will recognize these as being used for GI issues. So you have cimetidine, famotidine, and nizatidine. Famotidine is probably the most common one that I give in the hospital setting. So as I said, that it's better to prevent the reaction because these blockers, they can block the receptor, but they can't push the histamine off the receptor once it's already been filled. Remember the adverse consequences of histamine stimulation, which would be increased vasodilation, increased GI and respiratory secretions, increased capillary permeability, which is more inflammation really. So the antihistamines do have several effects. And so we can look at these effects here. So the cardiovascular system, so histamine causes dilation, increased capillary permeability. So when you give an antihistamine, that reduces blood vessel dilation and reduces the permeability of blood vessels. When you talk about smooth muscle, look here. So histamine causes salivary, gastric, lacrimal, meaning eye, and bronchial secretions in the lungs, but the antihistamine causes that to reduce. In the immune system, histamine causes these massive mast cell releases of histamine and other substances, so that causes allergic reactions, and antihistamines prevent that by binding to the receptors. Remember, the immune system releases those substances that are commonly associated with allergic reactions. There are also some other effects of the antihistamines, which are sometimes what we might use the medication to do anyways. But, for example, skin. So somebody has increased capillary permeability, rashing, itching, that will decrease that. Anticholinergic. So our anticholinergic drugs give us that drying effect. So We might give anticholinergic drugs to help somebody with the excessive eye tearing and itching eyes and things of that nature. And then some of the antihistamines cause drowsiness, some more than others, especially our traditional antihistamines. All right, so antihistamines, they are used for treating those symptoms of the common cold and upper respiratory treatment. Remember, they're just symptomatic management. They're not going to actually cure the underlying disease. And then management of everything you see here, everything from nasal allergies to Parkinson's disease and some sleep disorders. So they have a wide range of indications, and you'll want to take a look at your patient when you see an antihistamine and look at what antihistamine they're on, what's the dose, what's the route, and that will help you decide why your patient is taking it. All right, so let's take a look at some of the contraindications. Certainly you can pause on this and read through them, but obviously a known allergy to a drug would be a contraindication for the drug. Anything with narrow angle glaucoma because of the anticholinergic effects, cardiac disease, hypertension. Again, you'll see patients with these disorders on these medications. It's more of a caution. Peptic ulcer disease because of the role of histamine in gastric secretions and that these can be ulcerogenic. BPH, which is benign prostatic hypertrophy. So these folks already have a difficult time urinating, and these drugs with the anticholinergic effects can also cause a problem with that. Bronchial asthma, COPD, pregnancy, all right? Another contraindication is to give one of these medications, an antihistamine, as the only treatment during acute asthmatic attack, or for example, in anaphylaxis. We would the antihistamines are adjunct. The treatment really is epinephrine, albuterol. Those are for acute asthmatic attack and also for the severe allergic reactions, anaphylaxis. So adverse effects. So anticholinergic effects, these are generally the drying effects, and as a result, the patient really can't see, can't pee, can't spit, and can't poop. So lots of problems with dry mouth, urination, constipation, and drowsiness. Drowsiness is usually the main side effect that bothers people the most when taking these antihistamines. All right, so let's go on. There's a difference between the traditional antihistamines and these peripherally acting or non-sedating antihistamines. So the traditional antihistamines, they are the oldest of the old meds. They do work centrally as well as peripherally. And because of that, we have basically an increase in the central nervous system effects, which really is drowsiness. So these are where your diphenhydramine is going to live, right? So Benadryl, meclizine, promethazine. So look at the endings of these medications and try and remember that they act peripherally and centrally, so they're going to have more sedating effects. Now, the non-sedating ones, they were actually developed to try and get away from some of those unwanted effects of the centrally acting antihistamines. And you can see right on the package here where it says non-drowsy. So they were really working on that sedation, and they work longer. So, for example, if I was to give a patient chlorpheniramine under the traditional antihistamine, that has to be dosed generally like every 4 hours or so. Claritin can be taken once a day, and so this allows the patients to become more adherent to therapy. And the meds here, fexofenadine, loratadine, and cetirizine. Most common that you'll probably see is loratadine and cetirizine. All right, so nursing implications. So here's our money shot on these antihistamines. So remember to be very careful in patients with intraocular pressure increases, and these would be our glaucoma patients, anybody with cardiac and renal disease, high blood pressure, peptic ulcer disease. We already talked about that. The patient needs to be taught to report excessive sedation, confusion, hypotension. So that means we have to teach the patient about those being side effects potentially. You're not sure how a medication will affect a patient, so there's always the advisement to not operate heavy machinery and avoid driving. And also don't take any other substances that can increase the central nervous system depressing activity. Now, antihistamines should be taken with food, even though that slightly reduces the absorption of the drug, to minimize the GI upset that can occur. And remember, there's drug interactions, so the patient really should talk with their provider before taking any over-the-counter medications. And as patients are generally taking antihistamines because of secretions and things like that, we always want to encourage our patient to basically drinking extra fluids when they're sick with these sort of things that have congestion and cough. And treatment for dry mouth, right? So a patient will often complain of the dry mouth related to these medications. So making sure that they are brushing their teeth, rinsing their mouth out, keeping those mucous membranes moist. They can suck on hard candy, sugar-free is preferred, and chew on gum. All right, we're moving on to the next class of medication, and these are the decongestants. So there are three main types used. We have the adrenergics, which is the largest group. They are sympathomimetics. So think about what the sympathetic nervous system does. So these are ones that either stimulate or work the same way as that. The anticholinergics, not used as often for decongestants, and these are parasympatholytics, so the parasympathetic nervous system. Corticosteroids are generally topical and intranasal. And then of those decongestant types, there's two different forms generally. There's the oral form, and then we have either inhaled or topically applied inside of the nose. So you can see the picture there of the lady that's using a nasal drop, which is basically topically to the nasal mucosa. So one of the concerns with decongestants that we'll talk about more with the topical as opposed to the oral is the rebound congestion. So oral decongestants, they have a longer decongestant effect, so they're going to last longer when you take them, but a much more delayed onset, usually less potent than the topical, so patients may not like it as much. And again, no rebound congestion. These are obligate adrenergics, so they are only those drugs which basically are sympathomimetics. And our exemplar drug here is Sudafed or pseudoephedrine, a nasal congestant. Nasal decongestant. The topical nasal decongestants, in which you'll see the one that's most common here is oxymetazoline or Afrin. These are, patients like them, right? Because they are prompt, they are potent, so they work and they work fast for immediate relief of the symptoms associated with upper respiratory infections and common cold, things of that nature. However, if they are used beyond the recommended time, that it can cause rebound congestion, which is oftentimes worse than what they were treating for, actually. All right, so let's talk about, systemic absorption. Because these medications, even though they're sympathomimetics, they would have to be given in such huge doses to actually be absorbed systemically. That's not really an issue that they have. Usually the amount that is absorbed is too small to cause effects on patients that would be systemic. But if it were, these effects may be things like hypertension, palpitations, headache, nervousness, and dizziness, things of that nature. But again, usually in such small doses as somebody might be using this oxymetazoline or phenylephrine, doesn't usually cause that, but just understand that it could. Intranasal steroids are often used, and you'll see them and have to give them to patients and explain the teaching to them. So some of the most common ones that you'll say would be budesonide, which is Rhinocort, fluticasone, trade name Flonase. They are anti-inflammatories, as steroids are, and they are, commonly used. They can be used prophylactically to prevent nasal congestion in patients who have chronic upper respiratory symptoms. And then there's also an intranasal anticholinergic. So this would be ipratropium, so Atrovent. Yes, it's the same ipratropium that is part of Duoneb when we talk about inhaled medications. So the nasal decongestants, really because of their effect on the nasal mucous membranes, at the end of the day, it relieves nasal congestion. And other reasons that we may have patients using these medications would be for before surgery and even after, for patients who might develop like nosebleeds after nasal surgeries and such. And also any diagnostic procedures potentially to kind of open things up so that they can be seen better. So let's look at the contraindications. Are very similar to the other ones. So, of course, allergic reaction to this class of drugs would make it that the patient should not be taking the medication. Narrow angle glaucoma, cardiovascular disease, things of that nature. So again, you can read all of this. And remember, sometimes when we say contraindications, we don't mean an absolute contraindication. What we mean is to use cautiously with. All right, so our nasal decongestions. So adrenergics cause nervousness, insomnia, heart palpitations, so cardiovascular symptoms. Remember, it's really dose dependent. Excessive doses are more likely to cause systemic issues. In general, topical medications just exert their influence mostly topically. Steroids can cause dryness and irritation, so you may see that when you're assessing your patient. Interactions are here. Just remember, if we're giving a sympathomimetic, that other medications that also mimic or increase the activity of the sympathetic nervous system can cause increased toxicity. So you might see more signs and symptoms of this. Our MAOIs, using these can cause an increase in blood pressure. There's some interactions with methyl-dopa and also those medications which affect the urinary pH. As far as education for our patients, remember that caffeine is a stimulant, and these medications, these sympathomimetics, they kind of fall into that stimulant category. So we want to make sure that our patients are avoiding caffeine and caffeine-containing products. If they're not getting better, they should report that off to their provider. Maybe the time for symptomatic care is different, and maybe they need better care as far as maybe an antiviral or potentially an antibiotic. And make sure that the patient is getting better. All right, we look for what is the medication supposed to do, and we look for the patient to have an improvement in that symptom. All right, as we come into our last little section, I think it's mostly the last section, which we're going to talk about medications to treat cough. Remember that a cough is generally a protective thing. Patients cough because of secretions and foreign objects that are in the airway, so we would be able to cough these items out and up. So again, most of the time coughing is really beneficial for patients, but some cases coughing can be bad. So this would be excessive coughing, coughing after abdominal surgeries and the like. So there are times when we're going to need to treat a cough. All right, so the two basic types of cough. Coughs can be described as either being productive or non-productive. So productive coughs, the patient is moving stuff out of their airway, so out of their larger airways, and non-productive is that dry cough, generally more of a nagging sort of thing. So let's talk about our antitussives. All right, so antitussives, these are medications that are used to either stop or reduce the amount of coughing that a patient does. They can be both opioid or non-opioids, and they are used, again, only for non-productive coughs, or in cases where coughing is harmful. Remember, in general, a cough is beneficial. We don't want to stymie a patient's cough that's moving bacterial-laden secretions out of their airway. So contradictions are here for you. So being allergic. For our opioid antitussives, anybody with an opioid dependency, they may not be the right patient to receive that sort of treatment. And anybody who has respiratory depression. All right, so let's talk about the opioids. So opioids basically suppress the cough by working directly in the cough center, which is found in the medulla in the brain. Also, there's an analgesic effect, increases the viscosity of the respiratory secretions, which may or may not be beneficial depending on it. Usually we want to thin secretions to get them out. A reduction of runny nose, postnasal drip, so patients feel a little better. But again, we have a lot of central nervous system reactions to this, which is sedation and nausea, lightheadedness, people get constipated. The most common one that you're going to see for cough would be codeine. In fact, we have some cough syrups that have codeine in them. Not so common to see hydrocodone. So dextromethorphan is a non-opioid, but it does kind of work the same way as an opioid because it basically suppresses the cough reflex through the cough center. But though it doesn't cause CNS depression, it can cause some drowsiness, may cause dizziness, may cause nausea. Benzonatate, Tessalon pearls, which I find to be a completely adorable medication just because the way they shake in the bottle and the way they look, I like them. Basically, these prevent the reflex stimulation in the cough center and can also cause a little bit of sedation, drowsiness, dizziness, and others. So if somebody's on an antitussive, what are the nursing responsibilities? So we want to make sure we have a thorough respiratory and cough assessment, assess for any allergies, teach the patient about the central nervous system effects. Remember, they're going to cause drowsiness and sedation. Remember to make sure that we are making sure the patient knows to contact the provider if a cough's lasting more than a week, it's persistent, they have other signs and symptoms, and make sure that we monitor for the therapeutic effect of the medication. Of course, if we're giving an antitussive, which means something to stop them coughing, we would want to see a decreased cough. Now, in that same section of coughs, let's talk about expectorants. All right, so expectorants are drugs that aid in the expectoration or removal of mucus. So we want them to cough up the mucus. So these expectorants, what they're meant to do is by loosening and thinning the sputum, which we call basically reducing the viscosity. So thinner mucus is easier to cough up. So they can disintegrate and they can thin the secretions. We want to be very careful with these expectorants when patients who are elderly, those with asthma, and those with COPD. And remember that we want to increase fluids if it's not contraindicated with these expectorant medications. So we use expectorants to help patients with these common complaints here, which you can pause and read, but remember it's productive coughs. So the big takeaways for the expectorants: increase your fluids, okay? All right, and now let's wrap it up with a little bit of talk about herbal products. We have echinacea. Common uses of echinacea include stimulation of the immune system, for people who are feeling ill, treatment of viral infections, influenza-like respiratory tract infections, wound healing. But you can see here that there's some adverse effects, and these are not to be used by people with AIDS, tuberculosis, multiple sclerosis, some of our connective tissue disorders. And golden seal, which people often use for upper respiratory infections and some skin issues as well. It's contraindicated in patients with acute or chronic gastrointestinal disorders and during pregnancy because golden seal has uterine stimulant properties as well. Use it cautiously in those with cardiovascular disorders. And this medication, golden seal, can interact with antacids, histamine blockers, like H2 blockers like ranitidine. It can interact with proton pump inhibitors and also can interact with antihypertensive drugs. All right, guys, so we're going to wrap it up here. Sorry for the length of it. Here's your cartoon for the day, which is, I've been waiting for over 10 minutes. When can I get something for this cold? It isn't going to get better on its own. All right. Have a great day.